morning, good afternoon, good evening, wherever you might be. This session, I think, is going to be really interesting. We're lucky to have somebody from the Ministry of Health in Singapore, Sutowo Wong, who is joining us, and is going to talk to us about unlocking value from health data. So, Sutowo, welcome to this conference, and I will hand it over to you, and I'm going to start sharing your screen now. Thank you.
Thanks, JP. Hi, everyone. All right, so today I'm going to share a bit more about how Ministry of Health in Singapore unlock value from data. There's a bit of a journey that we have gone through, and I thought it would be useful to share the experience with everyone here. And hopefully there's something that we can pick up on here. Can we move to the next slide, please? So these are the different areas that I will be covering. There's quite a fair bit to cover, but I will cover quite quickly and see whether there are questions at the end. I'm happy to take any questions from anyone. Can we move to the next slide, please? So first, I'll start off sharing a bit on our operating context, so that you know the reason why we had to make some of the shifts that we are making, and also why we are actually doing quite a fair bit of the transformation that you're going to see. Can we move to the next slide, please? So before I start, maybe a bit about the Singapore healthcare system. It's not that different compared to many other systems globally, but the market share between private and public could differ depending on where you are. So we have preventive care, which is mainly covered by our Health Promotion Board. It is a government agency focusing on health promotion. Then in the primary care side, 25% of the market actually belongs to the public healthcare, where we have subsidized primary care called polyclinic. So they cover 25% of the market. 75% of the market are covered by private GP. And then on the hospital care side, on the acute care, the market share actually flipped. 80% covered by public hospitals and also our national specialty centers. And then 20% are actually with the private healthcare. On the aged care side, it's a lot more varied, mostly voluntary welfare organizations or VWOs. And there are many different types of providers, ranging from nursing home to daycare centers, home care services that are provided by the different organizations. So it's quite a varied sector when it comes to the aged care side. However, overall, if you look at the Singapore healthcare system, it is still very much hospital-centric. And definitely that's not something that's sustainable, both from manpower and also from a fiscal perspective. Can we move to the next slide? And at the moment, Singapore is facing a lot of demographic challenges, not unlike many advanced economies in the world. We are facing aging population. And as you all know, the seniors are more likely to fall sick, more likely to be hospitalized, and also suffer disabilities. There's also a rising prevalence of chronic diseases. That again adds a lot of burden to our healthcare system. And at the same time, we're also facing finite financing and manpower resourcing. The healthcare expenditure has been rising and rising rapidly. There are many things that we need to do to contain the cost increase. And of course, Singapore is not different from many other countries in the world where we are facing quite a fair bit of a very limited manpower when it comes to healthcare, especially nursing manpower. Can we move to the next slide, please? And of course, then, as a result of all these demographic challenges that we face, finite resourcing, whether it's fiscal or manpower, there's quite a fair bit of impetus for us to actually make some decisive shifts in two different areas. If you move to the next slide, I'll share a bit more about the different kind of shifts that we are making. This is a little bit on Healthier Singapore. I'm not sure whether you have heard of it. Essentially, it is a national initiative that we have where we are trying to make two shifts. One is the shift in our healthcare delivery model. The other one is on the financing model. So on the healthcare delivery model front, essentially what we are trying to do is to move upstream into preventive care and encourage Singapore residents to build relationship with their primary care doctors and co-create a personalized health plan that goes beyond the curative aspect. So you don't just go to your primary care doctors for cough and cold. You also go for your vaccination, your screening, and also look at health plans that covers the diet, physical activities, and other areas that will help keep our residents healthy. On the financing angle, we are actually moving towards capitation. So we started off with fee for service. At some point, a few years back, we actually moved and experimented with bundled payment, and now on capitation. For those of you who are not familiar, capitation essentially means that the healthcare providers are funded on a per capita or per person basis, meaning for Sutowo, for example, if the health system is taking care of me, they are paid a certain amount every year. And if they can keep me healthy and I don't go to hospitals, I don't utilize healthcare services, they get to keep the cost savings. So that we are hoping that with that, the incentives are aligned and the healthcare systems will also try to keep the residents healthy. And hopefully then we have a healthier population and achieve better health outcome for everybody. Can we move to the next slide, please? So this shifts actually fundamentally has to be achieved through behavioral changes. Unfortunately, today, many of the residents in Singapore still see, for example, primary care doctors as someone who is dispensing medication when it comes to cough and cold, and they need a medical certificate so that they can be excused or take sick leave from work. They need a medical certificate for that. And we are trying to shift the behaviors and the mindset that people have when it comes to primary care. And hopefully, digital technologies, AI can help to enable everybody. So we look at it from different lens. From the residents' perspective, we are hoping that they can be digitally enabled to pursue healthy living and to manage the health conditions. For the healthcare professionals, we are also hoping that they are digitally enabled to provide the appropriate care, monitor the patient's progress on their health plan, and also better improve the outcomes through the use of clinical decision support systems. For healthcare administrators and policymakers, we are hoping to have greater agility in policy development, implementation that's backed with strong insights, and also have faster feedback loop so that we know whether our policy and operations are actually working. Can we move to the next slide, please? But before, of course, we dive into the innovations, there are many foundational issues that we have uncovered along the way as we do our implementation. And I'll share a bit more about that. Can we move to the next slide, please? So this is very similar, right? Before we talk about the use of AI, digital technologies to empower residents, to empower our clinicians, and to empower our healthcare administrators. There are many things that needs to be done. If you look at the image, it's like trying to open a cupboard where the plates and the bowls are actually falling. It is not easy. You have to make sure that you're able to catch all the bowls. Don't let it break. And there are many of these things that we can do before we can have the party and serve the food. Can we move to the next slide, please? This is a very busy slide. I will not cover every single point. But what we have done is that we have actually interviewed close to 200 stakeholders across public healthcare system and look at what are some of the user experience that they have across the various data life cycle, all the way from acquisition to management of the data, access and distribution, and exploitation of the data. I'll just cover a few of these challenges that they face. One of which is that it actually takes quite a fair bit of time and money to actually collect the data. Often the data is stored across many different systems, quite fragmented. Just public healthcare system we have in Singapore, there are about 700 systems that we have. We are in the process of looking at consolidating many of these systems as we do our technology refresh, and also see how we can better consolidate and streamline operations. So if someone is looking at the use of data, they may have to extract data from multiple systems, and they have to go through the process of seeking approval to get the data extracted. And this extraction process could potentially take months depending on the complexity of the data to be extracted and the number of systems involved. And often after extracting the data, they also have to then look at how do they better harmonize the data. Because across the various systems, the data may be coded differently. Some may be using ICD-10, some may be using SNOMED. So we have to see, if you want to look at the data at the national level, the harmonization of the different codes being used, definition being used will have to be done, so that then we are actually looking at the things in a consistent way. And of course, when it comes to the exploitation side, there's also a lack of reusable data assets. Often people have to start from scratch, do their feature engineering, and come up with the data set that can be used for the analysis or model development, for example. And the process repeats itself because it's not being made into a reusable asset that other people can use. And therefore, everybody will then eventually end up duplicating many of the work that could have been otherwise. The work can be doesn't have to be done, and much of the effort can be saved, and then they can actually spend more time doing the analysis itself. So this was quite a fair bit of the pain points that we uncovered, and we actually put together a strategy to address many of these pain points. Can we move to the next slide, please? So this, in terms of strategy, again, looking at the same stages in terms of data life cycle. On the acquisition front, we have actually developed a data lake. It's called our Consolidated Data Repository. It has gone live. Now we are progressively ingesting the data, and there's a data management work stream where, like I said earlier, we try to standardize the codes being used. We try to harmonize the definition so that then we can look at things in a consistent way. From a governance perspective, we have clarified the legal basis on which the government is actually acquiring data from the healthcare providers, because these are private entities and therefore subject to our Personal Data Protection Act in Singapore, or PDPA. So we are actually utilizing one of the exceptions in the Act to actually acquire data from these institutions. So besides making sure that we have proper legal basis to acquiring or collecting the data, we're also making sure that the roles and responsibilities of various parties in this whole process of data sharing is clarified. And then if, let's say, in the case of an unfortunate event where there's a data breach, everybody know then what is their part and what kind of liability they may be subject to. And finally, on the exploitation end, we are also then providing the tools, reusable assets, data assets, as I said earlier, to enable the different people to be able to access the data, do the analysis, build a model. And on top of looking at the users within the ministry and our statutory boards or different government agencies, we're also looking at how we can share data with research at the moment. And hopefully at some point, as we gain more confidence, we also see how we can better share data with the industry. Can we move to the next slide, please? Of course, then these are the foundational areas, right? Where it creates value and unlock value really is on the use cases. And therefore, we are actually looking at what are the things that we can do, say from an AI perspective, what kind of business use cases that we can actually embark on and deliver. We have actually done an AI project many years ago, and there were many lessons that we have learned to help us see how we can better scale many of the AI innovations. Can we move to the next slide, please? So this is what we call Selena, Selena Plus. It stands for Singapore Eye Lesion Analyzer. It is a deep learning model that is jointly developed by our Singapore Eye Research Institute and National University of Singapore. It has been deployed to all our public subsidized primary care facilities. It's called polyclinics, and it's actually been used to serve many of the patients that we have to detect diabetic retinopathy. And now, using the same retinal image, our team is looking at how it can be extended to detect chronic disease, kidney disease as well, and other type of diseases. So the whole idea is that the same retinal image can be used to detect multiple diseases, and hopefully then the value proposition for the patient is also stronger. Can we move to the next slide, please? So this is the journey that I've gone through. Again, quite a long journey that I've gone through. I will not go through every single detail, but there were different phases that the project has gone through. For example, in phase 1, we did a proof of concept, a POC, that started with just 6 polyclinics. That was back in 2018, where we look at the result from AI versus what the human graders are doing. So the way it works is that there are two groups of human grader, primary grader and secondary grader. The primary grader will look at the retinal images and then look at assessing which are the ones that may potentially be abnormal, and they could be high risk of the patient having diabetic retinopathy. And then they pass these images along with 10% of normal images to the secondary grader. And the secondary grader will look at it again and see whether they agree with the primary grader. If they do, then you will go in terms of referral to the ophthalmologist if it is high risk. The low risk one, then they may be asked to come back again the following year for another checkup. And then the medium risk one, they will then escalate also to the ophthalmologist for them to take a look. And in the event where the primary grader and the secondary grader disagree with each other, it will also be escalated to the ophthalmologist. So at the start, it's really a proof of concept where we collect the data and see whether it works well. After we have proven that it works, in phase 2, then we deployed all 23 polyclinics. But even at this stage in phase 2, the results are actually used side by side with a human grader. And we're hoping that in phase 3, we are able to use AI to replace the primary graders, and we'll go straight to secondary grader. And that gives us an opportunity to redeploy the primary graders to be secondary graders and hopefully improve the throughput and efficiency of the operations. As I said earlier, we are using the same retinal image to try to detect other diseases, and in the process of testing and validating the model. And to support the commercialization of the work, we have also spun off a company, a private company. They have presence now in quite a few countries all over the world. Can we move to the next slide, please? So if you were to summarize on the lessons that we have learned, before we have Selena Plus, we have this Singapore Integrated Diabetic Retinopathy Program, in short we call it SIDRP. It is we created 2 central reading centers. So in the past, the reading were done at the polyclinic by the doctors. So instead of doing it in a decentralized manner, we centralize them into 2 reading centers, and that allow us to actually collect the data. And the data being collected then is used to train the AI model. So that is the important enabler, the data collection phase. Without SIDRP, actually there's no way we can build a model because the data is actually decentralized and in a way fragmented all over the place. And in addition to that, we also found that there are various hurdles that the team faced in terms of complex IT integration. There were many operational issues. There was also a gap between the research grant funding and the eventual scaling and IT deployment. So that's an area that we actually look at, and in the process, identify ways in which we can plug such funding gaps and barrier. Of course, there are other things like, for example, data privacy, data security, and then looking at how we can better scale through the use of cloud computing and governance of the AI model that's been developed. Can we move to the next slide, please? So now that we have looked at addressing the foundational issue, codifying the lessons that we have learned from our very first AI implementation, now we are trying to put all these lessons into our AI strategy, which has been implemented. Can we move to the next slide, please? So in our AI strategy is actually, if you boil it down to the core essence, it is actually quite simple. The part in blue is essentially what I call where to play. And then the part in green is how to win. So the where to play is essentially looking at our health system goals, healthy population, right and quality care, sustainable costs. And that comes then into what kind of objectives and outcomes that we want to achieve. And then that in turn drive the focus area for us. So that's where we do the use case selection. And we go to the part in green. Of course, we do not want our projects to stay as pilots or a small science experiment. What we want to do is, for those that are promising, that are delivering high impact, what we want to do is to be able to scale them at a national level. And therefore, it's important for us to look at the different enablers all the way from governance, IT infrastructure, looking at education and outreach, partnership with research, with industry, and also funding that I spoke about to make sure that we are able to bridge the gap in funding between research grant and also operationalization. Can we move to the next slide, please? And all this that we do in healthcare is aligned with our national strategy for AI. This is something I take for granted, but I realized after speaking with many friends from different countries, they actually commented to me that it is quite rare for such alignment at a national level. Of course, granted, Singapore is a small country, easier for us to align many of the work, but nevertheless, actually many of my friends from overseas have commented and they were actually quite envious of the fact that we are quite aligned in our national strategy. So healthcare is one of the sectors or key sector when it comes to our national AI strategy. We are now in the midst of refreshing this national AI strategy and something that we may be going to the public very soon. Can we move to the next slide, please? So I will start off with, if you recall in our strategy, there are two parts, where to play, and then there's the how to win part. I'll start with the where to play, some example of the use cases. Like I said, if you want to unlock value, we have to go to the use cases and make sure that we deliver value. So in this case, we are looking at a couple of things. This is what we do during COVID. On the left-hand side, the use of natural language processing, when you apply that to identify the symptoms from the clinical notes, or to see whether or not there are patients who are suffering from acute respiratory infection, and using that to do a spatial temporal projection so that we know where the cases of ARI may emerge in different parts of Singapore, so that then we can see whether there's certain trend that we need to be mindful of and whether there are some transmission clusters that may help us uncover some public health actions that may be taken. On the right-hand side is the use of phylogenetics, so genomics data that allow us to look at the relatedness of the COVID-19 virus subtypes. When we apply that with a traditional epidemiology investigation, what we call backward contact tracing, allow us to identify the source of infection and whether or not we need to close down certain venue and do a decontamination of the area. This is different from forward contact tracing, where we are trying to stop the chain of transmission. So the people who are in close contact with the case may be asked to stay at home so that then they don't transmit the diseases to other people. But of course, these were some of the things that were done early in the COVID, where we actually, the understanding of COVID wasn't that well. And also the population was actually not immune to the disease. There was no vaccination at that time, and therefore, whether backward contact tracing, forward contact tracing is highly critical to our fight against COVID. Can we move to the next slide, please? This is a research project that is administered by AI Singapore, which is an organization looking at how to help Singapore organizations adopt AI. So this is a research project. We are there now in stage 2. The objective of this is to look at how we can stop or slow progression of diabetes, hypertension, hyperlipidemia by 20% in 5 years. It's a lofty goal, but this is something that we use as a North Star for the researchers who are actually in this program. So the winning team is called Jarvis. They are now in stage 2, where after building their models, they are looking at multi-site validation. There are 4 different areas that they focus at. One of them is primary care decision support, and then there's specialist care decision support, screening, and most importantly, behavioral nudging. As I said earlier, there's a lot about that we can do when it comes to behavioral change, and therefore the behavioral nudging part is extremely important. We're using AI to see how we can nudge the patients, for example, compliance to medication, how then we can encourage them to take up certain programs that help them keep a healthier lifestyle. Can we move to the next slide, please? This is another project. It's called Pensive. It is the use of AI to detect dementia in the community. Today, dementia, the detection, or if you look at the gold standard, it is not easy. It requires literacy on the part of the person being screened. It also depends on healthcare professionals who are trained, highly trained professionals. What we want to do is to see whether we can use AI to enable the detection of dementia early in the community, So the whole concept is quite simple. The seniors are actually asked to look at a series of drawing, and then they are asked to repeat those drawings in the same sequence that they are shown. And that is used then to detect whether or not the patient could potentially be having dementia. And if they are deemed as higher risk, they will then be sent to a memory clinic in the hospital for us to do the gold standard test and screen, so that then we know for sure whether this person has dementia. And that data is used to then further use to fine tune and train the model. So hopefully we are able to do this at scale. The beauty of this is that because it's drawing, there's no need to depend on literacy. Unfortunately, because of the in the past, when our seniors are actually in their nation building era, there were many of them who didn't have a chance to get education. Some of them are undereducated, and therefore they're not literate, and it's actually very difficult for us to administer many of the other tests. And in this case, we are able to do that because it's based on the drawing. And it's quite fast and can be done by a non-healthcare professional who's actually trained in the methodology. Can we move to the next slide, please? This is something that is done in our hospital on the use of CT scan. CT scan is one of the most overused assets in a hospital, and therefore we want to see how we can better optimize the use of it. In this case, for the purpose of diagnosing the appendicitis. So based on the clinical notes, we are able to then look at whether or not it is a definite case of appendicitis, or is it probable, or it is not appendicitis at all. For those that are definite, there's no need to go for a CT scan. You should go for operation immediately. For those that are not appendicitis, again, there's no need to do CT scan. But for the probable one, that's the one that we may want to focus on and send them for CT scan. So that allows us to actually optimize the use of this precious resource in the hospital. Can we move to the next slide, please? Of course, it's not just on the clinical end. We're also looking at the application of AI to look at our operations as well. In this case, we are using machine learning to identify non-compliant claims. We run many financing schemes. There's a universal health insurance that is run nationally by the government. And what we do then is to see how we can use machine learning to identify non-compliant claims, for example, outlier detection. Hopefully then they help us to keep the premium rise in check, because we are able to weed out fraud, waste, and abuse. Okay, move to the next slide, please. Another one is from a planning perspective. We do quite a fair bit of planning with regards to where we want to site healthcare facilities. For example, for the next hospital, where do we want to site it? Which part of Singapore? Yes, it's a small country, but we also look at a regional and local level, whether or not there's a greater mismatch between supply and demand compared to other places in Singapore. And that's where we may potentially want to then put, say, a new healthcare facility, whether it's a hospital or a polyclinic, for example. Can we move to the next slide, please? Another one is on situational awareness. We are now under quite a fair bit of stress in the healthcare system where there's bed crunch. So we are monitoring the healthcare utilization in the form of bed occupancy rate, waiting time, to make sure that we know when we need to activate any of our plans to do load balancing across different hospitals. Also, that's something that we do at near real time and allow our decision makers in the ministry and also the healthcare administrators in our public healthcare clusters to actually be able to do that. Can we move to the next slide, please? Okay, so now you have seen quite a few examples in terms of use cases on the kind of examples of how we use AI, how we use data to deliver value. How do we then make sure that a lot of these things are not done and doesn't stay as a small science experiment, but instead we are able to scale them at a national level. So let's take a look at some of the enablers that are important for us to help us in the deployment. One of which, of course, is talent. To do AI, we need talent across various areas. It's not just data scientists, it's not just AI professionals. We're also looking at the need of data engineers. We need business analysts to look at how they can translate the business requirement into the technical side. We need people who are working on the platform. We need people who are doing software engineering to be able to package whatever that is done into an application that can be used by the different people. Of course, program managers who can make sure that things are running on schedule and we are able to then deliver on time and on target. Can we move to the next slide, please? This is something that has been published a few years ago. It is our AI in healthcare guideline. This is used because actually, if you look at the regulatory landscape when it comes to AI, our Health Sciences Authority, for those AI that is defined as a medical device, they actually go through a certification process with HSA or Health Sciences Authority. As when it comes to in-house build models, actually, because these are not commercial AI product, they are not considered as an AI medical device, and therefore we want to put forth some form of guidelines to allow hospitals and the implementers of AI solution in healthcare to be able to look at what are the things they need to look out for when it comes to the development and implementation of AI solutions. Can we move to the next slide, please? Of course, the guideline state is actually in a form of many principles that needs to be adopted by healthcare organizations. That in itself is not sufficient when it comes to implementation. We recognize that if you want to implement something, we need to then look at the project life cycle and going step by step, the entire process, providing what we call risk prompts, the questions that the project team will have to ask themselves so that they make sure things like, for example, is the data being used to build a model representative of the population for which the model is going to be applied to? And then, for example, when it comes to deployment, after they have deployed the model, do they continue to monitor the drift in performance of the model? Because we all know AI models actually have a performance decay over time. So we have to monitor the performance decay and know when's the right time for us to retrain the model with new set of data. So these are some of the things that we do, making sure that there are risk prompts over the entire process through which people are actually developing the model and deploying the model. This helps people do the implementation of the healthcare guidelines that we have published previously. So this is still work in progress. We are hoping to be able to publish this so that we can help healthcare institutions in looking at how they can better operationalize the guidelines that have been published before. Can we move to the next slide, please? This is on the data platform side. As I mentioned earlier, we have the MCDR, which is our data lake. This is the green part on the top right-hand corner. It takes not just data from our public healthcare institutions, it also takes data from other government agencies because as we all know in healthcare, there's major determinants of health that's coming from the social front. So we call it social determinant of health. And therefore, it's not sufficient to look at healthcare data. We want to make sure that we also combine that with social data from government so that then we can have more holistic view of individuals and better be able to then look at how we can help them. On the bottom right-hand corner, there is the platform that's being used to serve our public healthcare institution users. This is within the healthcare sector. They are private entities and therefore they have their own hosting environment, they have their own data and their own platform. On the left-hand side is our data exchange platform that allows us to exchange and share government data with the industry and with the research side. So research, we also focus more on high-value research cohorts that has been built over the years and make sure that we are able to capitalize on this research cohort as data assets and being able to then combine that with other data to make it even more helpful in answering many of the research questions. And hopefully the research outcome will benefit more Singapore residents. Can we move to the next slide, please? This is an example of a minimum viable product. Imaging is a very big area for us when it comes to AI. So we are building a minimum viable product for medical imaging that is then integrated with the various imaging systems, the RIS-PACS systems in the various hospitals. So the whole idea is that once the integration is done, we're able to train and deploy model to any institutions, make it very seamless, as opposed to today, whenever we have a new model or it is a bespoke silo implementation at each institution, which can actually take up significant resources and manpower. Can we move to the next slide, please? Of course, beyond the areas of talent, beyond the platform, beyond governance, we're also looking at how we can better enable the rest of the people. These are not necessarily data scientists or AI engineers. These are the people whose day-to-day job is not data. We want to make sure that they are also enabled with the ability to look at the data so as to help do their work in a better way. So we have a competency framework there are 4 different levels to it, from basic to intermediate to advanced and expert. The people whose day job is not data will cover more basic and intermediate level, and those people who are data practitioners, for example, our data scientists, they will go to advanced and expert level. And it's not just a competency framework, but we actually match that with relevant training courses that they can actually take up if they want to build up certain competencies. So then it's very clear to them, if I take up this training course, what is the kind of competency that I'm building? If I want to take the role of a data scientist in a healthcare institution, what kind of competencies I need to build, and therefore what kind of training courses I need to go for. And hopefully for people who are interested in it, they can at some point, if they want to transit from a non-data role to a data role, they can also actually do so, hopefully in a less painful manner. Can we move to the next slide, please? And this one is on privacy enhancing technology. We recognize that Singapore is a small country. There are areas where our data, even at a national level, is not sufficient. And therefore, there's where international cooperation will be helpful. For example, in the area of rare diseases, where there are very few cases in Singapore, we are hoping to be able to work with international partners. And of course, there are continue to be some concerns when it comes to sharing data, especially where you have to send data to a central location for the training of the model. So today, the concept is that we are bringing the data to the model. So we are pulling the data together in a central location. And the fundamental premise is that the various parties or data contributors have to agree where they want to send the data to. And that takes a lot of trust, and that takes a lot of effort in overcoming many of the impediments, whether on the governance end, from regulation end. So now we are testing another concept where we bring the model to the data. So instead of pulling the data together in a central location, we bring the model to the data, we train it on the data at its original location, and then we bring the model back and merge them together. So that then do away with the need to actually share and flow data from one place to another. And hopefully that will unlock many opportunities for us to be able to collaborate with our partners overseas. Can we move to the next slide? Okay, last bit about generative AI. I think it's very difficult to talk about AI and data without talking about generative AI. Can we move to the next slide, please? So we've been hearing a lot about ChatGPT, Claude, Bard, all the different large language models. Question is that, does that change our strategy? And what are the things we need to look out for those of us who are actually looking into LLM or generative AI? Can we move to the next slide, please? So essentially, in our mind, there are a few dimensions that we look at. First is on the data side. If you look at the experimentation and deployment of LLM, first is that whether we are actually using publicly available data. I'm not sure whether you've heard of many high-profile cases where IP is leaked as a result of the use of such online tools. For example, Samsung engineers actually try to use it to debug their code, and they ended up sharing their codes with the rest of the world. Of course, we have to be careful when we actually use such publicly available online LLM tools out there. So if you are using publicly available data, no issue, go ahead and use it. There is no loss even if the whole world knows what you're trying to do. But if you're using classified internal data, of course, then you have to be careful. Then there's a need to see whether is it sufficient for you to fine-tune open source LLM, an existing one, or do you have to pre-train it from scratch? That depends on your sector, that depends on the use case. I would say most of the time, actually fine-tuning an existing LLM will suffice. But of course, there are some situations where you may want to then pre-train the LLM from scratch. apart from the data itself, there are other considerations. For example, is your application public facing or is it internal facing? If it's public facing, of course, the risk is higher. Internal facing, I think there is some risk, but at least your internal employees can actually catch it and then feedback to you. That allows you to actually update and enhance the tool. And then the use case itself, whether it is used as a productivity aid, for example, as a co-pilot, versus information retrieval. For someone who is retrieving information, they will take it as a gospel truth and the fact. And therefore, the accuracy of the answers provided by the LLM tools is actually very important. So by looking at sort of a 2x2 matrix on whether it's public facing versus internal use, productivity aid versus info or information retrieval, that allow us to see what's the risk level and therefore what kind of mitigation actions that may need to be taken. I think that is all that I have. Thank you very much. I'm happy to take any questions and see whether there's any questions that you have based on my sharing. Thank you.
All right, thanks so much. This was very interesting. We have a few questions. I have one which I've been biting my tongue, waiting for the end of your presentation to ask it. How does your organization look at the technology that you need to do all of this? How are you organized to make technology choices? So the background to my question is this entire track is called the CDOIQ toolkit. And toolkit is, these are all the things that we're doing. Well, what is the foundation, and in particular the technology and process foundation that you're using? And I'm very interested in government and in the Ministry of Health. Like, how do you do this, right? You talk about data lake and stuff like this, right? But when you actually need technology, like, how do you do this? Can you talk a little bit about that?
Okay, thanks for your question, JP. So the way we look at it is, it goes back to the business objective. So often we have to start from there, because otherwise we could be then building technology for the sake of technology.
Of course.
So really going back to what we need, what are some of the business problems that we are trying to resolve. But in this case, we are trying to bring the data together. And we are not just bringing structured data. So why data lake? Because we are also bringing some unstructured data in the form of clinical text, for example, the clinical notes from the hospital. And therefore, that is the way that we have organized ourselves in terms of technology, getting the data lake. And we recognize that we want to bring as much data as possible into the lake upfront. As I said earlier, there were many pain points when it comes to data extraction. Often people go at a use case by use case basis. They will then extract the data, right? And use case A and use case B may have 80-90% overlap when it comes to the data required. And they will re-extract the data because the person delivering A doesn't know that there's B, and B doesn't know that A exists. And therefore, they will do it independently. And they will do a lot of duplicative work. When it comes to then the choice of technology, what the process that we've gone through is that we actually started with some proof of concepts because there are some clear use cases that we want to test. There are some peculiarities in our data, and therefore we want to make sure that the technology that we select is able to help us overcome or address many of the peculiarities in our data. We try to address as much of that upfront. Of course, we can't do it 100%. There will still be things that fall through the crack, and therefore the process is not easy. There's much effort that everybody's putting through, not just the team internally within the ministry, but very grateful for our technology partners for working very closely with us in resolving many of the issues that we find along the way.
And do you have sort of inside the Ministry of Health, do you have your own IT department that drives the decision making on technology, or do you outsource this to a large system integrator, or do you have a sort of government of Singapore wide, nationwide IT department? Like how does that work?
Yeah, thanks for your question. So we do have an IT department within the Ministry of Health.
Okay.
These are made up of secondees or officers who are seconded from, we have a central government technology agency. They are the technology agencies that serves all public public institutions or public agencies in Singapore.
Okay.
Ministry of Health being one of them. So some of our colleagues in the IT department are seconded from GovTech or Government Technology Agency. When it comes to technology implementation, we work very closely with them. On the healthcare side, because we are extracting data from our public healthcare institutions,
Yes.
who are actually corporatized entities, meaning they are private entities. They work with a health technology agency by the name of IHIS, Integrated Health Information System. So they are the health technology agency that helps our public healthcare institutions with the IT needs. So for them, we also work with them so that they can help us extract the data and ingest it into the data lake that we build in our government hosting environment. So we actually work with both agencies, and
Right.
we do have a small IT department who can help us with the assessment of the tools and working and coordinating with our colleagues from the other tech agencies.
Got it. Got it. Okay. So I can see a question here from Bhavna. So this is related to the training programs that you have. And the question is, what are the types of training for each persona, and what each type of role goes through what kind of training?
Okay, thanks for the question. So I didn't go through the details earlier. At the individual level, it goes into the individual development plan. So it's not just a competency framework and then the associated training courses at a high level, but at the role level, at each individual level, each supervisor is expected to go through with the different officers under his or her charge to actually go through them on a yearly basis at the beginning of the year. What are the projects that you are expected to do? And because of that, what kind of competencies that may be required to deliver on those projects? And then that manifests itself in the form of an individual development plan down to the type of courses that they go through. We have different type of officers focusing on different things. We have some health economists. In this case, many of the training will be around econometrics. We have actually some colleagues who are looking at more data science type application of machine learning or AI models. For example, we are looking at prediction of patient bill. How do we predict patient bill in advance? When the patient comes to the hospital, often we want to be able to see based on the diagnosis, what could the eventual bill size be? And use that information to see based on the income of the patient, does he or she likely need, say, for example, some financial help? And therefore, what will be the kind of financial help they can go for, depending on the income level. And that is done by the medical social worker, but they have access to the estimated bill size so that then they can have this conversation with the patient as early as possible. So different personas delivering different projects will require different competencies and therefore different type of training courses that they go through. But all this then is individualized in the form of an individual development plan.
And would you say that most of the courses, which are in the area of data, right? Because this is what we're talking about. Would you say that the majority of courses are your own? You developed those courses, or do you send people as part of the development plans at the individual level? Do you send them to standard classes, whether it's at some university in Singapore or something organized by, I don't know, AWS or IBM or another organization?
Okay, thanks for your question, JP. It is a combination of the two. So we are starting to look at how we can customize the training. So we started off as a journey. When we first started off, we took some of the courses out there in the market. We saw the ones that could be relevant to us. What we do is to contextualize to our situation, the kind of use cases that we see and the kind of data that we have. And because we don't believe that someone going through a theoretical training will be able to do the job. So what we want to do is to have hands-on exercises. And the hands-on exercises, we actually make sure that we are using our own data. So that as the person goes through the training and do the hands-on exercise, when they come back and do their job, they are actually seeing similar type of data and will not be something that is like totally different from what they have encountered in their training course. So we started off by customizing some existing training courses out there provided by different providers. Now we are also looking at how we can essentially look at the bespoke needs of the different roles within the ministry, and then running some training sessions that are actually designed entirely by the in-house team. So my team look at competency development as well. We are in the process of rolling out some of the in-house developed training courses, and hopefully be able to then see whether it can help our colleagues better tailor to the unique needs for the different roles.
Interesting. Okay. Another question I see from Alexander. How are we considering the legal implications of data privacy and data protection while deriving value for health data?
Okay, that's a great question. So for all the work that we do in AI, in data analytics, we actually do not need identifiable data. So we made it very clear, all our analysts and data scientists, when they analyze the data, they're actually analyzing de-identified data. De-identified, not irreversibly anonymized, because at some point, if you look at, for example, the analysis of data, if we find something wrong, it is also our duty to see whether we need to inform the patient. And therefore, if there's a need, there's an approval process that the analysts will go through. They don't see the actual data. They pass the, let's say, the list of patients for whom certain interventions may be needed. Then this goes through an approval process for us to be able to re-identify the individuals. The analysts don't see the re-identified list. It goes to, say, for example, the clinician directly, so that then the doctors can see this is the list of patients for whom there may be certain interventions needed. Sometimes it's outreach, but again, the analysts do not see it. So we don't deal with identifiable data. And from a governance perspective, we also have different type of users for which we actually allow certain type of data to be made available. There will be those who are actually just project analysts. They don't deal with data day in, day out. There's an approval process that they go through. If they have a project, the project will have to be approved first, and then they look at what kind of data is needed, and then the data will be provisioned within a limited period. For example, if the project is 6 months, the data will be made available to them for that 6 months period, after which the data access will be removed, and they no longer have access to the data. And we actually do it in a central environment. It's not actually, the data are not downloaded to the various machines or devices that they're using, whether they're laptop. They actually connect to a central server for them to be able to access the data. Then the data stays there, unless, again, there's a need for us to actually extract the data out. Again, there's an approval process for that. So actually, we are quite tight when it comes to governance of the data and access to the data. And we practice the 5 SAFEs framework, looking at the kind of projects that people are going through. Who are the people accessing the data? What kind of output are they generating? Could there be then a possibility of re-identifying individuals through the output? We look at the setting. How do we protect the systems? Like I said, no downloads to their individual devices. So these are things that we look at when it comes to managing the data protection.
Okay. And so in you had a slide which is a bit of the overall architecture, data architecture, that shows there is a data lake, and then how do you have a separate infrastructure for the data that you exchange with industry and all of that, right? Your central data lake has all the information that has all the sort of person identifiers and addresses and names and all these things, right?
No. So actually, in our data lake, there are different zones. So there's a red zone where the identifiable data lands. We still need identifiable data because we want to be able to link up the different data.
Of course, like your clustering
sources.
use cases, right? With clustering requires detailed, yeah, okay.
Yeah. So there's a red zone where the identifiable data lands. And then it goes through automated treatment to actually remove some of the unnecessary personal information. And then some of them are pseudonymized. We have a tokenization process where we actually replace that with tokens. And then there's a key management system that we use to manage the keys that are used in the tokenization process. Then they go through an orange zone where our data engineers actually go into the zone to look at the data and make sure that they have already done the right tokenization and unnecessary personal information has been removed. And then before it goes to the green zone, and that's where then the analysts will have access to the data. Of course, depending on the access level and the role that they play, some may have access to more data than others, and these are provisioned into their individual workspace for the project. And then when it's not required from project perspective, then the access will be removed accordingly, depending on the type of access that they have.
Got it. Okay, that makes sense. So another question on AI is, you talked quite a bit about the use cases and that the fact that the Ministry of Health AI strategy derives from a nationwide AI strategy and set of guidelines. In the US and in Europe, there is a lot of talk about regulating AI. And having guardrails that make sense for AI, which is really difficult to do when the lawmakers are not necessarily deep in the understanding of AI and its potential and where it's going, right? The regulatory needs to be future-proof. So it's not just about what is needed today, but a regulation is what is needed several years down the road. From where you are, how do you see the government of Singapore approaching purely the regulatory aspect of AI in terms of guardrails, in terms of safety and things like that? Can you talk a little bit about that?
Sure. I think this is a great question. So before I talk about AI, let's talk about data first, right? So we have a Data Protection Commission, Personal Data Protection Commission, PDPC. They look at data protection, and in their work, their guiding principle really is that how do we manage the tension between innovation using data and consumer protection, and there's a balance that needs to be struck. And I think they've done quite a good balance between the two. When it comes to AI, you're absolutely right. We need to have guardrails. If you imagine driving a car and there's no brake, there's no way we are willing to drive fast, right? The guardrails is an example of that is a brake in the car. If you have no brake, the brake is not working, we will be driving very slowly. And hopefully with the right guardrails in place, we are able to accelerate innovations as well. So we do have an offensive view when it comes to governance, especially when it comes to AI and data. On the use of regulation, actually, we tend to not jump into regulation, at least in the first instance, because we recognize there's still many things that we are learning. The sector is still evolving. There are many different users of AI that are emerging. Like for example, now there's large language models. And therefore, the approach that we take really is issuing guidelines. So we issue guidelines. We co-create first the guidelines with the industry to make sure that the guidelines make sense and addresses a real industry need. And then we will publish the guidelines and make it available. Sometimes it comes with tools. For example, our AI Verify toolkit that is actually created or developed by our Infocom and Media Development Authority, IMDA. It's actually made available to different companies out there who wants to use the toolkit. So we issue guidelines, we create toolkits to enable organizations to actually look at putting together the guardrails when it comes to the use of AI. So that's generally the approach that we take. And there are some cases in healthcare, for example, not quite AI, but say in the area of telehealth, where we at that point in time didn't really understand too much about it. The approach that we took is to create sandboxes, regulatory sandbox, and we invite the providers to come in where we collect the data about the use of, say, telehealth in this instance, and then for us to monitor the safety and efficacy of the use of telehealth. So that is generally the approach that we take in Singapore. We tend not to jump straight into regulation. We tend to rely more on guidelines. If there's a need, we'll collect data, create a sandbox environment to let the providers come in and hopefully operate with guardrails, and for us to also collect data and have a better understanding of what it is before we decide whether there's a need for regulation.
Interesting. Okay, very interesting. Well, thank you very much for these great insights and for a great presentation. Thank you, Sutowo. I'm sorry. And thanks for the audience. So this is the end of this session, and stay tuned for the next one. I think in half an hour on this track F. Thank you, everyone.
Thank you.